Hi, everyone. Happy Tuesday. Hope you're having a good week so far. Happy spring break to those who celebrate. I'm Nina Sanford here at UT Southwestern in Dallas, Texas. So today we are going to be moving up the GI tract into the esophagus and the G junction. So what do I think about these sites? I think there have been a lot of new practice-changing studies that have come out. There's ESOPEC, Matterhorn just came out with a press release. So I am going to try to give an overview of management of esophagus and GEJ cancers, incorporating some of the new data. We'll talk about diagnosis, obviously. We will talk about early stage disease, lots of nuances there. Obviously, locally advanced, based on my talk at GI ASCO. We'll talk about stage 4. We'll talk about my thoughts on organ preservation, some stuff on mismatch repair deficient tumors, and radiation planning. So let's go ahead and get started. This is Esophagus GEJ Cancer 101. So let's go ahead and start with diagnosis. These are typically found on EGD with biopsy. The two main histologies are squamous cell carcinoma versus adenocarcinoma. Know that TNM staging is actually different based on histology. Within adenocarcinoma, there is a range going from the more well-differentiated types to more poorly differentiated, and some of these can have signet rings. What markers do you need to know? So for all tumors, you want to know mismatch repair deficient status. And then for stage 4 only, you also want to get PD-L1, HER2, and Claudin 18.2. That helps determine first-line systemic therapy, though I'll say in practice, sometimes we get it for non-stage 4 tumors as well. You want to know the measurement of the distance from the incisors, and that ranges from cervical tumors at 15 to 20 cm from the incisors, to distal esophagus, to G junction, which is typically, but not always, at 40 centimeters. It's important to understand the Seward staging system and know the Seward stage. The picture is on the right. This is for G junction tumors, ranges from type 1 to type 2 to type 3. Type 1 is right above the G junction. Type 2 is so-called true G junction, and type 3 is in the proximal stomach. It's important to know if the tumor is circumferentially involving the esophageal lumen and the degree of obstruction. If the patient is obstructed, they may benefit from stenting with or without palliative radiation. Our main imaging is a PET CT at baseline. If the tumor is above the carina, you also want to get a bronchoscopy to rule out a fistula. We also do a diagnostic laparoscopy for G-junction tumors, acknowledging that the yield is lower than for gastric cancers, but still somewhat high in signet ring cell tumors, and that would obviously change the patient's stage prognosis and potentially treatment. Important for all these patients to understand their baseline nutritional status to decide if they need additional feeding strategies such as a PEG tube. All right. Let's start in terms of management with early stage disease. And I'll be the first to admit, I was a little bit embarrassed going over this, that I actually didn't understand all the nuances of this. And thanks so much to my GI colleagues for explaining them to me. So first thing to know is that initial endoscopic resection is recommended for staging of early stage disease, ranging from in situ to T1A to T1B, so all T1 tumors. And a pictorial is below representing or demonstrating the depth of invasion with the T stage. What are initial endoscopic therapies? So they include EMR, endoscopic mucosal resection, ESD, endoscopic submucosal dissection with or without ablation. ESD is generally recommended over EMR for larger tumors, about 1.5 to 2 centimeters. What qualifies as definitive therapy depends on the histology and the depth of invasion. That's very important to understand for these early stage tumors. So if you have an in situ or T1A tumor, regardless of histology for this stage, but if you have a superficial T1B but adenocarcinoma only, then endoscopic therapy alone is sufficient, presuming they have negative margins, they're well differentiated, and no LVI. However, if you have a superficial pathologic T1D, but you're a squamous cell carcinoma, and then either histology if you're non-superficial, and then a high-risk T1A, either histology if they have ulcerations, LVI, poorly differentiated, or positive margin on initial therapy, then they need further surgery, oncologic surgery with esophagectomy. Why is that? Why is there a difference between squamous cell carcinomas and adenocarcinomas? Sorry, just looking at a page. It's because the risk of nodal mets is a lot higher for squamous cell cancer. So even with the pathologic T1B, the risk of nodal mets is about 15 to 20% for a squamous cell cancer versus much lower, less than 5%, some series, even 1 to 2% for an adenocarcinoma. At the other end, if a patient has a T2, now we're talking about muscularis propria invasion, but they're low risk, less than 3 centimeters, well differentiated, no LVI, then they can get an esophagectomy alone. Anything else, pathologic T2, that's not low risk, and anything higher, then the patient is going to need multimodal therapy, including esophagectomy with chemo, with or without radiation. Okay, so let's talk about locally advanced adenocarcinomas. And I split this into adenocarcinomas, and we'll talk about squamous cell cancers next. If the patient is a surgical candidate and they can get full FLOT, then the standard of care is perioperative FLOT. That means 4 cycles of FLOT, surgery, and then 4 cycles adjuvantly. That is based on the FLOT4 trial, which randomized patients to FLOT versus ECF, and the ESOPEC trial, which randomized patients to cross versus FLOT. And the OS curve from the ESOPEC trial is here on the right. What about adding immunotherapy to FLOT? So the Matterhorn study was that trial assessing IO, FLOT plus or minus IO. Today is March 11th, just a few days ago, the press release came out showing an improved event-free survival. This was done in gastric and GEJ cancers. Obviously, we want to know more information. Hopefully, that'll be presented at ASCO this summer. We want to know obviously the absolute numbers. Event-free survival is also a composite endpoint. It'd be good to get some breakdown on that. We want to know OS when it's mature. We want to know PD-L1 stratification. And of course, this was gastric GEJ cancers, not esophagus cancers. That being said, I think probably down the line, there will be a role for FLOT and IO, but TBD. If the patient is not a candidate for full FLOT, then the first thing you can do is dose-reduce FLOT, and we typically go at 75%. And then another option is this cross regimen, preoperative chemoradiation with carbotaxol, followed by surgery, and then adjuvant nivolumab if they have residual disease. That's based on Checkmate 577. Other questions one might ask. So is there a role for radiation? So after ESOPEC and then Top Gear, which was published a couple of months later, I don't believe pre-op chemoradiation for this patient population is a standard of care, presuming they're a FLOT candidate. However, I will still consider pre-op radiation if they have a poor response to FLOT on imaging or if they're still at risk for an R1 resection. Also consider post-op radiation, acknowledging that we always prefer pre to post-op if they have a poor pathologic response to FLOT, positive margins, or extensive lymphadenopathy. What does that mean? A really high nodal ratio, nodes with ENE. I acknowledge that there's no level 1 evidence supporting radiation in these scenarios, but I think they are settings where the risk of local recurrence is high enough to warrant at least consideration of an additional local therapy. If we're doing radiation, we use a cross regimen. What about induction chemotherapy? So this is based on the CALGB 80803 study, which looked at induction chemo with FOLFOX or carbotaxol, then chemoradiation with either the same or alternate chemo, depending on the patient's PET response. This is an important study, but the limitations were that it was phase 2. The primary endpoint was pathologic complete response. And then importantly, it wasn't a direct comparison to cross or peri-op FLOT. But in my opinion, it does provide data for this strategy of induction chemo followed by chemoradiation, particularly now in the FLOT era in patients who don't respond to FLOT, as I talked about. And then if the patient is not a surgical candidate, then we do definitive chemoradiation, which I'll talk about next. For squamous cell cancers. So if the patient's a surgical candidate, in my mind, the standard of care is cross with chemoradiation with carbotaxol, surgery, and adjuvant nivolumab if they do not have a PCR. Important to remember that ESOPEC did not include squamous cell cancers. And why is that important? 2 things. 1, squamous cell cancers tend to respond better to chemoradiation. 2, they also tend to respond better to immunotherapy, and based on the Checkmate 577 trial. There are ongoing and published studies, such as this Japanese trial, that assess chemo and surgery without radiation. But in my mind, there are some limitations before extrapolating my patients. 1, these were Asian patients, which may be biologically different and different in other ways in US patients. And these patients also did not get adjuvant nivolumab. Now, what if the patient is not a surgical candidate? Regardless of histology, you're going to treat them with definitive chemoradiation. So not surgical, meaning they're medically inoperable or the tumor is unresectable. We typically give carbotaxol. Some places also use FOLFOX. The radiation dose is a topic of controversy. Know that pretty much all radiation dose escalation trials have been negative. You can see the table to the right, ranging from the intergroup study in the early 2000s to Art Deco and Prodige, published a few years ago, mostly squamous cell cancers. So for non-cervical tumors, I typically go to 50.4 gray, and that's what NCCN says. Sometimes maybe 54. What about cervical tumors, particularly squamous cell cancers I'm referring to here? So practice patterns vary widely. Some will still dose escalate to 60 gray or higher, like head and neck cancer. Acknowledging, though, that there's no level 1 data supporting that in the esophagus. That being said, in all these trials, the proportion with true cervical squamous cell cancers was low. So take that as you will in practice. All right. Other topics that I think are important to know about, though I don't go into nitty-gritty detail, non-operative management. So non-operative management, organ preservation has become understandably more popular across GI sites, starting with anal cancer, rectal cancer, and now esophagus cancer. Patients clearly want, if they have an option, to keep their organs. It's not yet supported by modern level 1 evidence. There were older trials in squamous cell cancers, but there are several ongoing studies. The largest study with some data available is the SANO trial. So this was a phase 3 cluster randomized trial, included adenocarcinomas and squamous cell cancers. These patients received the cross regimen, 41.4 gray, so they didn't get initial chemotherapy. And then if they had a clinical complete response, and that was 300 patients, they're randomized to surgery versus surveillance. The initial results have been presented, but not yet published. And what did they show? They showed that OS was non-inferior for surveillance at 2 years, and then patients who had surveillance instead of surgery had better quality of life at 6 and 9 months. What we do not know yet, I don't want to call them caveats or just things we don't know yet, is we do not know the breakdown of patients between squamous and adeno. And most hypothesize that squamous cell cancers are more represented in this study. I think we need longer follow-up than 2 years. And also, we don't yet know the optimal response assessment and surveillance regimen for patients that go through this non-operative management strategy. All right, I need to take a break to answer a page. I'll be right back. Okay, sorry about that. I'm back. So let's talk about stage 4 cancers. So similar to any disease site, if a patient has stage 4 cancer, you want to start with chemotherapy. And then I would consider consolidative local therapy if there's limited residual tumor, so-called oligometastatic cancer. And I think the best data for that is a randomized phase 2 trial from Shanghai in squamous cell cancer. There is an ongoing phase 3 ECOG trial testing that strategy in the US that is currently accruing. What about first-line chemo? So obviously this is sort of a complicated topic, but I try to simplify it and boil it down to sort of the high points. And thanks to my med-onc colleagues for helping me with this part. So for adenocarcinomas, if the patient is HER2 positive, you start with FOLFOX or CAPOX, add a HER2-directed therapy with trastuzumab, and then if they have a CPS score of at least 1, you can add Pembro as well. If they're HER2 negative, then you also start with FOLFOX and CAPOX and add immunotherapy with Pembro or Nivo or tislelizumab if their CPS score is at least 1, or zolbetuximab based on the GLOW study if they're Claudin 18.2 positive. Note that generally immunotherapy is category 1 if the patient's CPS score is greater than equal to 5, and category 2A if their CPS score is 1 to 5. And I should just backtrack and say this is obviously US guidelines, NCCN, and practice patterns and approvals may probably differ globally. For squamous cell cancers, it's a little bit more straightforward. I start with FOLFOX CAPOX plus nivolumab. Note that there are other immunotherapy options that are used, at least for us, less frequently. This tislelizumab, which is very hard to pronounce, Pembro, and Ipi-Nivo. Sorry, my lips are really dry. Okay. What about mismatch repair deficient tumors? So this is about 5 to 10% of G-junction esophagus tumors. For these patients, you want to start or consider starting upfront immunotherapy. That can be Ipi-Nivo, Durva-Tremi doublets, or Pembro. There are phase 2 trials showing a pathologic complete response rate of about 60%. Obviously not as high as the 90-100% in rectal, but I think still promising. One is this French study listed here. And then, of course, the question is, if they have a clinical complete response for locally advanced, is there a role for non-operative management? I think that is an open question, but certainly something that patients are very interested in. So I just summarize that algorithm here. This is from my talk at GI ASCO in 2025. This is for locally advanced tumors, Stewart 1 and 2, esophagus GEJ, divided first into whether a patient is a surgical candidate or not a surgical candidate, divided by histology, and then if the patient is eligible for FLOT. Of course, in January, Matterhorn results had not been released, or at least event-free survival had not. I think PCR had, so that is not included in this diagram. That being said, I don't think it's been approved yet anyway. So I think this is a reasonable framework for March of 2025. All right, last part is on radiation planning. So if you are a non-radiation oncologist, you can zone out if you want, or listen if you want. But generally for simulation, I use intravenous and oral contrast. The patient is NPO. For distal esophagus and G-junction tumors, I do a 4D CT, and they're immobilized in a baclock bag. What about dosing planning? So I do 45 and 50 grain 25 fractions with a simultaneous integrated boost. That being said, note that the cross trial used 41.4 gray. So anything between 41.4 to 50.4 is an acceptable dose, say if you're taking the boards. IMRT is standard. IMRT is approved for esophagus GEJ cancers. You will probably be asked by someone at some point on protons. So know that there is a phase 2 randomized trial showing lower toxicity burden, mostly in the form of post-op complications with protons, as published in the JCO a couple years ago. There is a NRG phase 3 randomized trial accruing that should answer that question hopefully definitively. The endpoints are OS and cardiopulmonary toxicity. I believe also a trial in Europe. What about target volume? So I do two. The high dose is going to be the primary tumor plus a 1.5 cm mucosal expansion superiorly and inferiorly. The nodes get a 0.5 to 1 cm expansion, the gross nodes. For low dose, similar primary tumor with a more extensive expansion, 3 to 3.5 centimeters. Know that for distal tumors, you want to cover the celiac nodes and the gastrohepatic nodes. That is the area between the stomach and the liver, kind of like that strip of tissue. And then anything above the carina, you should also technically include the supraclav nodes. You always crop out, or I always crop out of the heart, crop the low-dose CTV out of the heart, lungs, and vertebral bodies. Those are not natural routes of spread. I do include the aorta at the level of the primary tumor. My PTV is 0.5 to 0.7 centimeters, depending on my daily imaging. Here are Timmerman constraints that we have for conventional fractionation. We use for esophagus, we use for lung cancer. I think if you're taking the boards, just memorize one set of constraints for one part of the body. For adults, obviously, peds a little bit different. All right, that was a little bit of a whirlwind. That is what I have for esophagus GEJ cancers. I'm always open to any feedback about these videos. Let me know what you like, what you don't like. And otherwise, I hope you have a great rest of the week and take care. Thank you.